Welcome to Better Health Guy Blogcasts, empowering your better health. And now, here's Scott, your Better Health Guy. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal medical authority.
Hello, everybody, and welcome to episode number 32 of the Better Health Guy blogcast series. Today's guest is Dr. Shawn Naylor, and the topic of the show is Unique Approaches to Lyme Treatment. Dr. Shawn Naylor completed his undergraduate training in human physiology in 2001 at McGill University in Montreal. He earned his medical degree from Touro University College of Osteopathic Medicine, California in 2005. This was followed by a traditional rotating internship and residency training in family medicine at St. Anthony Hospital in Denver, Colorado. He has completed more than 700 hours of continuing education training, mainly in osteopathic manipulation, functional medicine, prolotherapy, neuraltherapy, ozone therapy, and autonomic response testing. Additionally, Dr. Naylor has been an instructor in prolotherapy and is a member of the American Academy of Ozonotherapy, the International Lyme and Associated Diseases Society, and the American Osteopathic Association. Dr. Naylor believes in the science of conventional medicine. However, he has also been influenced by the teachings of A.T Still and Dr. Dietrich Klinghardt. He's come to believe, as did Dr. Still, in the body's ability to heal itself given the right conditions. Dr. Naylor feels that many who fall through the cracks of conventional paradigms can still be helped. And now, my interview with Dr. Shawn Naylor. So I am excited to have Dr. Shawn Naylor on the show today. I originally met Dr. Naylor through Dr. Klinghardt's conferences about 10 years ago. Welcome to the show, Dr. Naylor.
Thank you, Scott. It's a pleasure to be here. And thank you also for the amazing website that you've put together for all of us. It's such a labor of love, such a great resource. There's nothing like it out there, and
Thanks.
I really appreciate it.
Yeah, and a lot of the stuff there is probably stuff that I've learned from you over the years as well. So it's
I'm sure I've learned at least as much from you. So it's good to have each other. Thank you.
So let's start with how you got drawn to focusing your practice on people with chronic illnesses such as Lyme disease. Did you have personal experience with Lyme or someone that you knew?
Yeah, I mean, I think that the personal experience thing is true for just about every Lyme practitioner I know of, whether they like to talk about it or not, and a lot of them don't. But I mean, the interesting thing maybe about my story is that I got a tick bite when I was 6 or 7, living here in Colorado, and at the time we had a house that was in Boulder, right on the greenbelt. So deer would come down from the foothills right up to the fence in the backyard, Lyme is about as far away as you're supposed to be able to get, or Boulder is about, Colorado, is not really anywhere near the endemic Lyme disease maps. And 20 years later, I lit up the Igenex Western blot like few people that I have seen since, and clearly Babesia and Bartonella as well. So it's interesting that I'm a good example of that kind of bad information coming out of the CDC.
Well, and I think the good thing is I know you're doing well today, and so I think that gives people hope as well to know that people do get through these things and that there is life beyond Lyme disease. I think that's important for people to have hope and see other people that have managed to do that.
Yeah, I'm working full time. Got 2 little kids, so awesome. I'm living it, if nothing more.
Yeah, that's great. So one of the things that I wanted to talk a little bit about was osteopathy and the importance of structure. Since you are an osteopathic doctor, how important is structure in chronic illness, and what are some of the common threads from a structural perspective that people may need to address to move their health forward, even with something like Lyme disease potentially?
I saw you most recently at the Forum for Integrated Medicine, and I think 4 of the first 5 speakers specifically mentioned osteopathy as a great referral source for them and their Lyme patients. And I couldn't help thinking, not only am I an osteopath who isn't really doing much of that stuff, despite having thought at one point in my career that that was all I was going to do. Um, but also there are three other physicians in my office now that all do osteopathic manipulation and all like doing it, and I'll take insurance doing it, and I'm not really. I feel like I'm underutilizing that as a referral source, but there's no question that osteopathy was a big part of my recovery. Well before I knew I had Lyme disease, I got some cranial work for birth trauma that definitely changed my life, and maybe more than any other setting, kids who've had traumatic deliveries, I think, can respond really dramatically and quickly to osteopathic manipulation. And so things like, colic, poor latching, even reflux, I've seen those things just, go away in a couple treatments, and those can be tough problems. And so I just wanted to put that plug in, not for necessarily me, who doesn't really do that stuff, but for people, parents who might be struggling with that.
So I know that Dr. Klinghardt has been one of both of our mentors over the years, and I know that you do use autonomic response testing as part of your evaluation of a patient that you're working up. So in addition to labs and all the other things you do, how does ART help you determine how to move forward with a patient?
It's big, Scott. I'd like to think that it. I don't know if I'd like to. Yeah, I'd kind of like to think that I could make more decisions on more objective data and have more strong science to use to defend myself if somebody's questioning what I'm doing. But in terms of doing what is right for the patient, certainly now, the more I do it, the better I get at it, and the more I kind of know, especially at the beginning of treatment, where I could get going without maybe even doing the muscle testing. But gosh, it's such a hugely variable disease, and I think it's just a really valuable tool for working your way through otherwise extremely murky waters. So I just a quick story. I had a patient 3 or 4 years ago who came in and he had double vision, and I don't even think he knew what Lyme disease was. He wasn't really coming to me for that. He heard about me from somebody else, and that was really his only symptom. And his Igenex blots were meh, and he didn't have a history of a tick bite, and he'd been to the ophthalmologist and the neurologist and the neuro-ophthalmologist, and nobody really had any answers for him, and it was quite debilitating. And within 4 or 5 months, he was totally fine again. He muscle tested for viruses and Borrelia, and I gave him some stuff, and he got better. And so I think, gosh, without muscle testing, I would never have arrived at the right conclusion, even if I had $1 million to do, out of network lab tests.
Yeah, and I know that without ART, I would have never recovered my own health. I mean, some of the things that came up over the years from ART really led me down paths that were very, very productive. And no system of testing is perfect, but ART certainly has changed my life in a very significant way. So I agree, it's difficult to imagine being able to navigate these things without it. And then the benefits of being able to take something like ART and really personalize the things that you're doing. I mean, you talk about personalized and individualized medicine. I mean, this is a great tool for being able to do that. So you talked a little bit about some of the science. Let's talk about lab testing. Are there specific labs that you find really helpful these days for Lyme and co-infections? What are you primarily focusing on?
That's really just recently changed for me, Scott. I was using mostly Igenex and mostly just their Western blot with a little bit of eye spot testing for the first 6 or 7 years of my career, and only in the last 6 months have I really pretty dramatically shifted to using the DNA Connections urine test whenever it's appropriate, which is most of the time early in treatment. I don't know exactly to what degree that test may be ruined by, or if somebody's been on treatment, you're more likely to get a false negative. Presumably, I don't know how true that is, but that test is just not getting the press that I think it deserves. I know Klinghardt's talked about it. You may have heard it discussed at other conferences that I didn't go to, but it's pretty reliably showing positive in a fairly indisputable way for the key players, Borrelia, Bartonella, Babesia, Ehrlichia, all showing up often, if not most of the time. So, I mean, and $500 is actually pretty good value. You don't even need a blood draw. That's kind of what we've all been wanting and hoping for a long time. People, there's no good test, and now there is, and so I think more people should be using it. I'm not compensated in any way by that lab, for the record.
And it's really interesting. I mean, I have lots of thoughts about that test. I just listened recently. Leslie Douglas was one of the speakers on the Chronic Lyme Disease Summit 2, and she went into a lot of detail about the test and even what they're planning in terms of enhancing it to broaden the number of types of Borrelia into some of the other ones, like Borrelia mayonii, which is a newer one that's been out. It doesn't currently handle some of the European strains, and so they're adding some of those in. But I personally did it many months ago and did still pick up some things, even though I haven't had symptoms of any of those for a long time. And I know that when I had some conversation with Dr. Christine Schaffner from Sophia Health, and one of my questions to her was, do you generally have people stop their antimicrobials for some period of time or not before you do that? And she said they weren't really finding that necessary, that they go ahead and continue on with treatment. And they still, in fact, Dr. Klinghardt also spoke on that summit, and he had mentioned that out of a sample size of 200 tests that they had done, that they only had 3 negative results. So it's a pretty high percentage. The last I talked to someone at the lab, I think they said 93% of the tests that they do, they find at least some positive on the list of things that they're looking for. So, I think it's an interesting test. I hope that it holds up over time. I mean, it sounds really helpful for people. I know Dr. Klinghardt thinks that it's been very, very useful. And then he's kind of extended that recently to using the ultrasound and those techniques that he came out with a published paper about recently to increase the potential for getting some of those bugs into the urine so that they come up in the test. And then I know that they also do some type of heavy body work, rolfing or deep tissue massage or something before the test to try to liberate some of those organisms that aren't generally found in the blood. So it's interesting, but that's great to hear that more people are starting to use it. So thanks for sharing that.
I do think that it's missing still some Babesia, and maybe more ultrasound or deep tissue or whatever could assist with that. But I think that the naysayer who's listening thinks that, oh my goodness, it must be false positive if it's so frequently positive. But you have to remember how strong a selection bias you've got in your group of people who's getting this test done. Nobody is getting this test unless there's already a clinical suspicion that's high. And so I think I don't think that the high rate of positives is indicative of false positives. So
yeah, that's great. That makes a lot of sense. I doubt there's too many healthy people paying $500 to have their urine tested.
Right, exactly.
So let's talk a little bit about the microbial aspect of chronic illness. So of the microbes that you see commonly in your patients, which ones do you think produce the most symptoms? And then maybe it's the same, maybe it's different, but which ones do you think are the more difficult to treat effectively?
Sure. I feel like certainly the majority of the people when they first come to the clinic and they're looking at something from at least 3, if not 4 of the 4 kingdoms, bacteria, parasite, fungus, virus, and often something from all 4. And so I think that very often most of those things are opportunistic secondary infections. So I try to make the distinction between an opportunistic secondary infection and a co-infection. In most cases, you've got both, but the opportunistic secondary infections usually much easier to get rid of. I think in a lot of cases, if they're not too deeply entrenched in 4 months, you can have pretty much put those things to bed. And in some cases, you'll have somebody who's just got tougher viruses and they need more treatment. Maybe they need some prescription antivirals, but actually, I think that the prescription antivirals are an adjunct to the natural antivirals, which are good enough for 80 or 90% of people. I've been talking forever about what used to be Endrestol and is now Reboost, which I like to combine with Virographis, and I don't know. I haven't. My PAs find that as effective as I do. I don't know if anyone else there is using, but I see a lot of people where they've been to holistic integrative whatever providers, and they had tests for Epstein-Barr, and maybe it was consistent with chronic or active or unclear, but then they weren't giving any treatment. And I said, well, gosh, I mean, if somebody took the time to test for this, they should treat it. And yeah, from a conventional medicine perspective, there's not much that's useful. But those two botanicals, well, the Reboost is mostly homeopathic, but together for a couple months works really well. And only a handful of people still need more treatment after that for viruses. Similarly, a lot of people have some fungal overgrowth. Maybe it's just candida. And if they're not living in a moldy house, that maybe come up later, but you can usually take care of that within a few months. Intestinal parasites, things like para-A and Alinea do a lot for a lot of people in that realm, especially at the beginning of treatment. But there are certainly people who seem to have much more serious, deeply entrenched parasitic infections that I think what we're dealing with is macroparasites that have left the digestive tract. So often some of the most debilitated people get their most profound responses to Biltricide. I've given at least a half dozen or more people boatloads of Biltricide and had them get wicked die-off, but less and less with each round. And so I've seen, that's not a big chunk of people. Maybe it's only 3 or 4%, but there's some people out there who have deep parasites that seem to respond to lots of that medicine. So that's an interesting scenario that I haven't heard a lot of people talking about. And then finally, I really find that Bartonella and Babesia are the most difficult things to eradicate. Period. Borrelia sometimes is tough. I don't generally struggle with much Ehrlichia, but yeah, the Bart and the Babs, they're tough. They're usually the last men standing.
Those would have been my two choices as well.
Yeah, so it's nice to have an emergent
Bartonella
consensus.
a little bit more over Babesia, but those definitely would have been the same two I would have chosen. One of the things on the viral topic that I've been excited about was something that we talked about in the podcast I did with Dr. Raj Patel, where he's using narrow-band ultraviolet B light therapy to cause the body to create its own vitamin D. And it seems to be really beneficial for the viruses in those people that have VDR receptor issues. And so that is something he's been doing for quite a while, and I've been doing it for about 6 months, and I'm pretty excited about it. I know at least energetically, after about 4 months, the viruses stopped coming up for me personally, so that was kind of a exciting
That's
thing.
really interesting. Yeah, I'll check into that. Thank you.
So let's talk then a little bit about Bartonella. So what approaches do you like to use for Bartonella? Do you use more natural things? Do you use pharmaceuticals?
I'm using both pretty much all the time. I really think that's the way to go, and I think that especially at the beginning of treatment, most people should probably be on a little bit of both. I would love to do it all with herbs, but and I think that with kids you often can, and even in kids, I like a little Tindamax, after a few months. I think that's really important for finishing off those cysts so they don't come back. But for Bartonella, I mean, I love Abart. There's only 2 drugs that I think are better than that, and those are rifampin, which I think is no big secret, but the pyrazinamide is new to me, and really I've seen some pretty dramatic things with that just in the last year or so that I've been using it. Really wasn't on my radar at all. I got to give Horowitz full credit for that. He was talking about dapsone and pyrazinamide, and I really can't get the dapsone to test very much. Maybe that's partly because I'm afraid of it. It is a little more scary. The pyrazinamide, like the rifampin, you can bump liver enzymes on that. And I had somebody recently whose liver enzymes were fine, and then I put it back on it later, and I said, "Oh no, you tolerated that the first time, so I don't think we need to necessarily keep rechecking your liver." And they bumped up, and she's okay now. But that makes me think maybe we need to keep checking. It's an easy enough test to do. But anyway, the pyrazinamide, despite rare incidences of liver enzyme bumps, seems to be maybe as good as the rifampin. I've seen some people who responded to one and not the other, and I don't know how to predict who's who, but things like where you've been treating somebody for a year and they're their peripheral neuropathy, the burning they got in their ankles and feet, just didn't do anything so far. And you put them on pyrazinamide, and you can get a real dramatic response. So that I've had a couple times, even in people who've done rifampin. So I'm excited about pyrazinamide.
Yeah, that's really exciting. I know for me, my worst symptom for years was head to toe burning sensations it was significantly worse in the legs and feet. And when I started really focusing on Bartonella, that was when it really resolved. So that's pretty amazing that this works so well for that. So let's talk then a little about Babesia, not only from a perspective of what you like for treating it, but I understand that you also have observed some unique things around people when they have a Babesia flare and kind of finding that as a useful marker for their potential response to treatment.
Yeah, and I'd be interested to know if you have heard anybody else who's observed this, but I've observed this phenomena fairly consistently. I mean, I've got to say pretty close to 1 in 3 people will have some version of it. And basically what's going on is typically when people have been in treatment for 4 to 6 months is when I'll see them starting to test for the cyst form stuff. And that's usually tinidazole, which I think is better tolerated than flagyl, which is metronidazole, and often shows up testing in combination with biofilm remedies, which makes sense to me because the Borrelia is it's probably the key biofilm player out of all of them. And I like the Regenemax and the Boluc for biofilms together, and the Tindamax for the cyst forms that are hiding in the biofilms. And it's interesting when that can be a kind of tenuous time in treatment because sometimes people will get a big flare of Babesia symptoms, usually when they've been on tinidazole for 4 to 8 weeks. And I didn't really know what to make of that before. It didn't make any sense. In most of the cases, people were on something for Babesia at the time. And the conclusion that I eventually reached that I feel pretty strongly about is that I think it has to do with the relationship that these infections have with each other, where they're competing. We talk about how they support each other and how having one makes it hard to get rid of the other. And I think that's true. I think they benefit from the immunosuppression created by their neighbors and friends. But I also think that there's a bit of a dominance phenomena going on whereby, a lot of people I think in Lyme are talking about, make sure you treat the dominant infection. And, that can be as easy as treating the one that seems to be, the best explanation for the worst symptoms. But I think that when, you've been on the right treatment for 4 to 6 months, you do the tinidazole, you do the biofilm stuff, I think that's when the Borrelia really starts limping, wilts, that's the word I was looking for.
Yeah.
And, whether it's gone or not at that point, I think the Babesia suddenly says, okay, now I'm top dog, and now I don't have to compete with you, and now I don't have to have you suppressing me because you're hanging on by your own fingernails. And so I see this spike in Babesia symptoms, and I've eventually figured out, usually I don't have to do anything about it. It's good news because it means that the Borrelia is really retreating. And usually the flare and symptoms doesn't last very long, and I just tell that to use that as an indication. Okay, now now it's more time for more Babesia treatment, and very often I'll find Primaquine testing at that point. I haven't heard a lot of people talking about Primaquine. I kind of figured that out. Well, I mean, I didn't figure it out myself, but I was researching malaria at a time when I was just feeling like I needed something else for my Babesia patients, and it's pretty well tolerated, and people don't get wicked herxes off of it, but it muscle tests a lot. I think it helps, especially at that stage in treatment. So that's useful. But then the one other thing I wanted to say about that Babesia flare was that sometimes it'll kind of go the other way on you, where people have been on the Tindamax for a while, and suddenly I'll see a worsening of neurological symptoms. And that is usually a person that's going to need to go on Bicillin. And I think what's going on there is that the Borrelia is relatively a little safer in the central nervous system. Maybe the blood-brain barrier is protecting it from drugs and antibiotics and herbs a little bit. And what I think is happening is that you spent those first 4 months kind of chasing the Borrelia so that it retreats into the corners and goes into the cyst form and waits out the antibiotic storm. And then you go in and finish it off with the tinidazole. and that's working in the body but not in the brain. And in the brain, it's going, okay, it's coming back out of cyst form because now the tinidazole is threatening the cyst form, and it's got enough resources, enough protection, enough safety there that it can go back towards the spirochetal form. So I think that is a good indication that you want to use bicillin, and most of the time that works, and you don't need to do the PICC lines, which you try to avoid.
Yeah, it's interesting, the idea about the immune system kind of focusing or prioritizing the dominant pathogen. That's something that Wayne Anderson talks about.
Yeah.
The idea that at one point in time, the Borrelia is the more significant thing, but as soon as you get that to a certain level, that then the immune system kind of shifts its focus, and then all the symptoms of the next dominant thing come up. I know he kind of uses that as kind of a guide in his treatment approach a lot. So that makes a lot of sense, actually.
Yeah, I totally agree with him on that level.
Let's talk a little bit about ozone. I know that you have used ozone in your practice for a while. I don't think we've actually talked about ozone too much on any of the previous podcasts. And so maybe you can just tell us a little bit about what is it that ozone does? What is it affecting or improving in the person in terms of microbes, toxicity, all of the things that are in play? How do you potentially introduce it? And then what kinds of shifts do you see in patients that introduce ozone as a therapeutic tool?
Sure. I don't know if I can answer all of those questions to your satisfaction. I think there's a lot that we don't know about ozone, but there's no question in my mind that it's a valuable clinical tool. I kind of came at ozone because I have a side interest in prolotherapy, and so I do some prolotherapy, and I think that kind of balances my professional life a little bit. And so I was hearing people talk about Prolozone, which is basically prolotherapy, but you throw some ozone in there. And it's a little bit different because most of the prolotherapy people have gone to, more intense training sessions where they're taught how to hit pretty small targets, especially ligaments attaching to bones in the, in various places of the body. And I think that the, Schallenberger ozone course is, hey, we'll do a weekend, we'll shoot some, shoulders and knees. And I think that kind of training is fine. And I think the ozone really helps the intra-articular prolotherapy injections, which some of the prolotherapy people kind of shy away from. They think, I don't want to just dump things in the joint. I want to be really peppering the ligament. And I think that's appropriate. But I think that ozone is a nice adjunct for that. But it's a really nice adjunct if you're just putting treatment into a joint. Putting ozone into an arthritic knee or shoulder really seems to enhance the treatment. And I really have lost interest in, I was never really getting into it too heavily, but the question is, do I need to do PRP or stem cell injections to really maximize my injection capabilities and therapeutic potential or whatever? And I'm not feeling that it's necessary to go to those things that are much more expensive. But how does ozone work? I think there are a lot of theories that probably have some validity. It has some antimicrobial properties. I'm not thinking that that's hugely, going to help a lot of Lyme patients. Really, I don't think you can kill off these things wholesale by using ozone. I think that that probably the therapeutic value has more to do with what is more well established scientifically, and that is an uptick in oxygen utilization that has been observed in tissues that have been exposed to ozone. And that is more profound than just the uptick that you might observe in the setting of oxygen administration. And so I don't think we totally know how this works. People talk about, the NADP and the mitochondria or whatever, but yeah, it does seem like tissues use more oxygen for days, maybe even weeks after they've been exposed to ozone, and that allows them to make more ATP, so they have more energy currency available for whatever they need it for. If that's a prolotherapy, it's rebuilding. If it's a chronically fatigued Lyme patient who just can't exercise or is still really fatigued despite all you've done to try to treat their infections and support their adrenals and whatever else you're doing. Sometimes ozonating the blood in those people can be pretty profound for exercise tolerance, exercise recovery, and fatigue. And so I have found it has a place there. I'm not some of the people who advocate for ozone, I think, are a little over enthusiastic about it and talk about it being a cure for Lyme disease. And I don't like that because that's not been my experience. I think it may be that there's a selection bias there too. Maybe some of those people are actually fairly easy patients that haven't, gone down the road of the kind of treatment that I would usually go down before getting a little desperate and maybe putting them on an ozone machine. Does that make sense? If you're starting with slightly easier patients, you're going to get better results. If I'm only using my toughest patients for ozone, it's not quite as profound. But if I select my patients well, it seems to help a lot of them.
Yeah, and I personally love ozone, but I also don't think that it stands alone in dealing with a chronic Lyme type scenario. So I think as an adjunct to other things that you're doing, I've seen a lot of people that have done really well, but it's not the only thing that they're doing. They're doing other antimicrobials, they're doing detox, they're doing coffee enemas. It's part of a broader protocol. But then in those cases, people often do seem to notice some pretty nice additional incremental improvements. So
yeah, I would agree.
Yeah, that's great. So how important do you think electromagnetic fields, EMFs and EMRs are for your patients? How do you recommend that they reduce or minimize their exposures? And when they do that, does it make a clinical difference?
I kind of want to hear what you have to say about this one. Maybe after I'm done telling you what I think, but I'm not exactly sure how to muscle test for it. Maybe that's part of my problem. Maybe I've seen people do it just by holding up a cell phone. I mean, maybe it's as easy as that, but I feel like everybody goes weak when you put a cell phone next to them. How do you does that mean that they should go to great lengths to try to shield themselves from electromagnetic fields? I've struggled with that. I felt like, it was nearly impossible even to get most of my patients to turn off the Wi-Fi at night, which seems like a not so unreasonable request. But and then of course, even if you're doing that, we live in a detached house and there's 20 or 30 Wi-Fi signals that are strong enough to stream high def on. So so how do you get away from that? So Klinghardt was talking a few years ago about the Y-shield paint and maybe putting the drapes over the windows and that I know was debatable even among the Klinghardt students about whether or not that's good enough. You can't really create a full Faraday cage that way. And so I knew I was tearing up the carpet in my upstairs. So I was like, okay, well, now's my chance to paint the floor with the Y-shield paint. And I painted the inside of the bedroom. And, painting is not a super expensive thing to do. And I had bought some of his field detection tools and I just didn't feel confident using them. And so I just kind of called it a day at that point. But then one of my patients introduced me to somebody who's doing this kind of work for a living. And I met with him and I really liked him. And I followed his advice, and we did some more Y-shield paint, and we'd already done the floor, so we did the ceiling of the room below my daughter's room, and even though that's not a perfect Faraday cage, he thought that would be good enough, and there was like 4 amps of dirty electricity coming into the house off of the water main. Because I think there's a lot of old houses in the neighborhood with bad electrical systems that are grounded to the same water main. So that was interesting. That was a $100 fix, and so we did that as well. We also put the most of the upstairs circuits on a remote, so you can just click that and turn them off unless you forgot to shut down the computer downstairs, and then you got to go down and do that. So anyway, that reduced the high and low frequency EMFs in those upstairs bedrooms in our house by 95, 97, 98%, according to his objective measurements, without creating a perfect Faraday cage, mostly without even a second coat of the Y-shield paint. And so it worked objectively. Do I sleep any better? No. My kids were not real sick to begin with, so they don't seem any different. So I guess I don't know. I was just kind of wanting to leave no stone unturned and experiment on myself, as I often do. And so I don't know. Clearly he did a good job. But how do I know if it's affecting people and whether it's worth them spending the money? I maybe
Well, and I think there are some people that clearly are more electromagnetically sensitive, that they can feel some of these fields and things. I do think that many of those people are also the ones that are more heavy metal toxic, that the heavy metals are kind of, serving more as an antenna. I personally do try to avoid it as much as possible. Fortunately, a lot of the Wi-Fi routers now have schedules built in where you can have them automatically turn on and off at different times of day, so you don't have to even think about it, which I think is nice. I have slept in the silver-lined Faraday cage that Dr. Klinghardt talks about for probably 12 years now or 11 years now. And I would get another one, because that's one where I can take the meter, I can see what the level of EMF is in the room, I can drop it down and I can see it go to essentially nothing. So I do think that for me, I think it helps. I don't think it's the biggest thing that I've had to do, but when you're struggling with trying to figure out what are all the things you can lift in terms of stressors off of your system so that your body can try to find its homeostasis again, I'm glad I did that. I certainly don't use a cell phone to my head. I don't have any cordless phones in my house, which for a 3-story townhome is sometimes a little challenging with one phone on the 3rd floor. I get my exercise that way. But, I think it's more difficult to avoid the exposures in the daytime than it is while you're sleeping. The good news is I think while you're sleeping is probably the more important time to minimize those so that you can get more restorative sleep and the body's kind of in a healing mode. I know when I talked to Dr. Klinghardt recently on one of the interviews that we had done, he also mentioned that propolis and rosemary taken internally seem to support the body so that it's not as affected by the electromagnetic fields around us. It's obviously not reducing them, but that seems to be one thing that we can also potentially do internally. So lots of tools out there. The Stetzer filters is another one for the dirty electricity that I've also done in my home office. And sometimes it's actually very interesting. I had a wireless printer that was connected through a cable. So I had the wireless piece turned off, but I had an EMF person come out as well to kind of double check what I was already getting. I'm not an expert in it. And they actually found that the printer was still producing this huge field, because even though it wasn't connecting to my wireless network for purposes of printing, it was still trying to connect to the manufacturer for like checking for software updates or something. And there was like some other mode. So, I mean, it was a pretty big difference. And then, things like Bluetooth headsets and whatnot, I try to minimize using those as well, but I do have one here. And it was interesting that if you take the headset off of the base station, the field that it creates just is amplified so much more, versus if you're not using it, then at least putting it back on the base station, it calms down. So, it's an interesting thing to explore with the meters and whatnot, but unfortunately, I don't think we're ever going to completely avoid it. So continuing to detoxify, reducing the heavy metals and those kinds of things, hopefully will make some people more able to tolerate it. And then I'm also interested in the DNRS, Annie Hopper's dynamic neural retraining system, because I know that a number of people have had the ability to reduce their electromagnetic field exposure sensitivity by using that system, which is kind of retraining the brain's limbic response to various environmental stressors. And so I think that's potentially worth looking at for some people as well.
Have you had many people or heard about people who, say, put up the sleep sanctuary and that was big and dramatic and changed their life? I feel like if you're going to ask somebody to spend a couple grand, you want at least a few of them to have that kind of response to it,
I don't know that I've heard the huge big response in adults. I think in kids, some kids on the autism spectrum, I think sometimes reducing the electromagnetic fields can really be helpful. But again, I think it's a tool, but have I seen a lot of people with those miraculous comments? No. Doesn't mean they're not out there, but no, I have not heard a tremendous number of them where just doing something like the canopy, completely shifted the direction of their health.
It takes a lot, and that's a factor. I think your answer is helpful, so thank you.
The next topic, however, I have found to significantly change people's lives, and that's mold. So, so I'm curious your thoughts on the impact of mold in the living environment and someone that may be dealing with chronic Lyme or another chronic illness. How do you recommend that your patients evaluate for mold? And then what are some of the things that you do from a treatment perspective if mold is part of the puzzle?
Yeah, the mold thing, I hate it for maybe obvious reasons. But it's so big. I just, if anything, I mean, I feel bad about the fact that I didn't address it more earlier in my career. And I think about patients that maybe were struggling with that didn't get better. And I mean, you learn, but I didn't feel like I had a good way of evaluating it. I've struggled with the Shoemaker labs, which I think are kind of hit and miss. And what I was finding was people would just keep muscle testing for antifungals, usually botanical antifungals, and they keep testing for them, and they keep not getting better. And then I'm like, you know what? I think you've got mold in your house, and we try to do Shoemaker labs, and we'd maybe get something, maybe wouldn't, and does that prove anything? I don't know. And then I try to tend them, do the petri dishes, which are never so totally clear and never terrible. So those were useless in my opinion. And then you'd have somebody, tell them they got to get their house tested, and somebody would come out and charge them $1,000 and do a bunch of spore counts and tell them it's fine. And then, 6 months later, when they're really sick, there's a 30-foot square, Stachybotrys community discovered in their basement that was completely overlooked. And so, but by then I had lost credibility, right? I told them they had mold, and the spore count said they didn't, and they said this guy's crazy. And so that's a liability too. So, what's really been a game changer for me is, well, two things. One of them is muscle testing mason jars full of air that people left out in various rooms of their house, and having a good mold inspector, and that's been working well, because I mean, it doesn't cost anything to bring in some mason jars, and I say, oh, you know what, I think the laundry room is bad, and the upstairs bathroom isn't quite right, and at least 9 times out of 10, my mold guy would find problems, everywhere that I thought there was a problem, and other places too in some cases, and so that made it suddenly something that was practical, something that was working. Still, though, I mean, can be super expensive, especially if you want to do the job right. And if you don't do the job right, you might as well not do it at all. You might try to move, except sometimes people can't afford to, and they're locked in a lease. And I mean, I actually just broke a lease that we have a second clinic now in Boulder, and we moved it to Louisville because it was moldy, and I came to an agreement and threw the guy $10,000, and he let us out. But like, that sucks.
Yeah.
It's really hard to get away from the mold problem. Like, we're really attached to our house, and I was just saying to you before the phone call that my other bathroom is torn out now, and I tore out the first one twice, and so even being relatively hip to this stuff, I've been missing it and under fixing it, and it sucks. But yeah, when people are fixing it right, I'm seeing the dividends. That's changing lives. They're finally turning around, and so it's big.
Yeah, and what I've observed is if someone is also dealing with Lyme, that it seems like you just have to throw so many antimicrobials and other things, and they make just a little bit of progress. But if they can get the mold piece addressed, they make more progress with less aggressive interventions. That it just like the resistance to becoming, to having their health improve just kind of goes away, and it just starts to become easier for them to get there. I know personally, I was doing really well for years, and then in 2015 had another significant mold exposure over a period of many weeks, and my inflammation was tremendously worsened over that period of time, and figuring out and getting out of there resolved it fairly quickly. But it's really sad to see how many people maybe are getting exposed to mold every day in their living environment and suffering and not really even aware of it. And then, it's interesting too, over time, I think the position has changed a little bit. Like years ago, it seemed to me that the message kind of from the shoemaker side was, if there's a big mold issue, then probably people need to move. But then it became more clear that if you're in the 25% that has these HLA predispositions to mold, that probably more than 50% of buildings in this country have a mold issue that maybe is going to be significant to you because you're more susceptible. So it seems that unless it's really bad, I'm seeing more people trying to, work with a good IEP and a good remediation company. And oftentimes that combined with some good air filtration system seems to give them a bump. If it's a really, really bad scenario, obviously it's maybe not solvable. But I always encourage people to look at that. I think everyone should at least do an ERMI if they're dealing with long-term chronic illness like Lyme disease. And it's not 100%. I've seen it miss cases, but a lot of times it's very enlightening. And then I also do like the idea of doing some type of energetic testing with air samples or other things. And just for people listening, this is very different from air sample testing that Dr. Shoemaker talks about, where they're looking for mold spores in the air, which is not generally very helpful. This is more of an energetic testing using something like Dr. Klinghardt's autonomic response testing.
Thanks.
So let's talk a little bit about parasites and viruses. You touched on them a little bit earlier, and I'm just wondering, how common is it for you to see parasites and viruses in your chronic Lyme patients, and then any additional thoughts you may have on treatment for those things?
Yeah, I think I actually jumped ahead of your and answered most of those key questions at the beginning. I really like the Virographis and Enderstall for viruses, and tougher cases I like to add a little prescription yeah, I mean, protozoa are big, and I really have seen some remarkable things. Once in a while you get a patient who doesn't have Lyme disease. There's just some otherwise healthy 70-year-old who's had this crippling colitis for 2 years, and he's seen 6 gastroenterologists, and you give him 6 days of Alinea and he's cured. And so I guess I didn't comment on the whole notion that the testing for parasites still seems to be inadequate. And maybe you found a lab that you like, but I was kind of enthusiastic about the diagnostic solutions, and maybe I didn't give them enough chance. I didn't run a lot, but I just haven't found a lab that's really good at picking up protozoa, or for that matter, macroparasites. I don't understand how you can send in formaldehyde a flatworm that's identifiable to the naked eye to LabCorp and tell them have them tell you it's not a parasite. I don't understand that. It's bizarre. I've stopped trying to understand. So if you treat them, they usually get better though. And so, but I mean that's not in keeping with the way that a lot of physicians think about health. I don't know. I'm not trying to be critical. It's just like I understand that philosophy that says, we're going to do the lab test and we're going to treat on the basis of the labs, and I think that it's important to realize that has limitations. And if you're a doctor who's not willing to go beyond that limitation, then that's okay. But sometimes it's necessary. So let's be open to what the patient needs, which is sometimes treatment for parasites that are hard to find.
Yeah, and I tend to for protozoa, I do like Dr. Raphael D'Angelo's Para Wellness. Yeah. My observation has been that he finds some type of protozoa in about 90% of the samples that are sent in, which I haven't seen anything close to that with anyone else.
Right.
Obviously, something like ART as well can be helpful, though. I think sometimes the body doesn't always identify parasites as significantly stressing, right? I mean, Dr. Klinghardt talks about the fact that sometimes they're also benefiting us in some way by concentrating the heavy metals, by helping to balance the immune response and things of that nature. So I suspect that even with energetic testing, that there probably are more people that parasites are part of the picture than even what's detectable with something like ART. At least that's been my observation.
Yeah, I think that's a really good point. I think we have very complicated relationships with microbes, and yeah, people are really protective of their microbiomes. I think maybe more so than they need to be. I think those things tend to bounce back pretty quickly. But the these are so sophisticated, these pathogens, and they have evolved in mammals for millions of years. And I think that it doesn't serve them to kill the host. It doesn't even necessarily serve them to make the host sick. I think they're not going to be afraid to do what they got to do to make you a better host to them. And sometimes that means you get sick, but sometimes I think it can be they can be actually beneficial to some degree. So hard to know. Hard to predict. Probably different for different people.
And it is interesting because I think so many people have the concept of killing the bugs is the way back to health. But you and I both know that we probably have 10 times more microbes in us and on us than we do human cells, or a significant number more. So the idea that we're going to eradicate bugs to become healthy again doesn't really seem realistic. And to your point, many of the bugs actually do something beneficial for us as well, right? I mean, there's things we couldn't do without them. So
I also think, sorry, can I say one more thing? Yeah. I also think that that the body seems to know just what to do with some of these medicines, whether they're herbs or drugs. I kind of imagine that when you swallow this pill that you need, that the body is saying, yes, I want to absorb that, and I know exactly where I'm going to take it. And I know from physics and physiology, you're going to say, no, this stuff is going to be equally distributed throughout the body. But I think that both absorbing it into the blood and absorbing it from the blood to a place where it's needed, I think those are things that the body knows how to do, perhaps through mechanisms that we don't totally understand. And I see it sometimes when I'm giving somebody a drug, especially a caustic one, that suddenly they will become intolerant to. And it's not like an allergy. It's like, oh, it's just making me nauseous. This is giving me diarrhea. And, and it was something maybe like Tindamax. I'm talking a lot about that today, but, they were on it for 6 weeks and suddenly it was giving them diarrhea. And I think that's the body saying, suddenly, I don't know what to do with this anymore. I don't want to absorb it because then I got to metabolize it. So I'm going to leave it in the digestive tract where it's going to, cause problems. And that's, now when I see that, I'm like, okay, great, stop it. It's exhausted its usefulness. And I think that's true for herbs too. And so, I think that it's not, most of these, even the antibiotics, I think are not too hard on the digestive tract if you need them, because the body doesn't let them mess with the microbiome too much. It absorbs them, takes them where they got to go. And also, I think that, when people say that, oh, the doxy wrecked my gut or whatever, almost all of those people, I think, had fungal overgrowth to begin with. And so if that wasn't treated simultaneously, then it became a bigger problem. But, most of my patients in the first, few months of treatment, they're on SF722 or an statin or, any of several other antifungals, and I don't see a lot of problems. So.
Yeah, and it's interesting in terms of how some of these things work, and not so much the pharmaceuticals, but with, some of the herbal blends and things that are out there now from, people like Byron White and Beyond Balance and Nutramedics and others. Sometimes people have really strong reactions to even half a drop of one of these herbal products. And so I often wonder that's probably not that half a drop was distributed to all of these places in the body, but I almost wonder if it's as much the frequency of that herbal formulation that then is having an effect in the body, because it's amazing how very, very small amounts of these things, and ultimately not that it was a bad reaction, because sometimes those are exactly the things that move people forward. So it is interesting to wonder, we probably don't really understand how all of these things work. There may be and this is kind of goes back to Dr. Klinghardt's work as well, but a lot of these things, there may be a physics way that they're working in the body rather than just the biochemical way that we normally think about.
Yeah, that's interesting. I agree.
So let's talk a little bit about two topics that come up a lot more now that I probably had not heard much about a few years ago. The first one being SIBO, or small intestinal bacterial overgrowth, and the second one being mast cell activation, which really seems to be even more recent and more of a hot topic right now than even SIBO. But I'm curious, how often do you see those? Any pearls that you might want to share about those two topics?
I've got a couple things to say about the first one, the SIBO one. I have never, and I'd be curious to see if you've had the same experience, but I've never had somebody muscle test for, I've never had somebody who came in with a diagnosis, like a lab diagnosis of SIBO, that didn't muscle test for a fungal problem in their gut. And so I think that's actually consistent with what I see clinically, which is that a lot of these people get put on rifaximin or whatever, and they notice that it helps, but then the problem comes right back when they stop it. And then, and I wouldn't usually treat it that way, but then often they'll have gone to somebody more integrative functional, and they got put on a more comprehensive protocol, and they did much better. And if you look at that protocol, there's some stuff in it that's antifungal. And so I think that the bacterial overgrowth is there, but I think it's mostly secondary to fungal overgrowth. And so, yes, sure, treat the bacterial overgrowth, but more importantly, treat the fungal overgrowth. And hopefully that doesn't mean they have to tear out their bathrooms, but they might. And so that's, I guess, my take on SIBO.
So it's interesting, and just to kind of tie it together for people. So when you say hopefully they don't have to tear out their bathroom, one of the things that I know Wayne Anderson also mentioned when we worked on an article for the Townsend Letter a few years ago was that people that lived in an environment that had environmental molds generally also had more resistant internal fungal issues, and whether it's the colonization of those things, or whether it's just because mold and fungus is so similar, so the body then has more of an issue with their candida and other things. I don't know if that's entirely clear, but it is interesting that I have also talked to people that had ongoing fungal issues, and as soon as they left their moldy home, their fungal issues resolved with minimal treatment as compared to what they were doing before, which was all kinds of things that they just didn't seem to get a handle on it. So.
Right. I've climbed that ladder and be like, oh, the SF722 didn't work. Oh, now it's Afun. Now it's Agramax. Now it's itraconazole. Now it's amphotericin B, and nothing seems to be working, and I keep getting fungus. So yeah, I think that's when you got to look at the house. But I feel like that perspective is lacking from the sort of shoemaker camp, which doesn't seem to acknowledge that it's an infection. And I mean, maybe that's a questionable use of the term, but a colonization. I think this stuff is growing and living in people, and I think that it should be killed. And I mean, the cholestyramine doesn't do that. And maybe if you remove from the source and you fix the house, which is the first step, of course, and everybody's shoemaker protocol, then okay, maybe the immune system can do the rest now, and you can just move on to the cholestyramine. But I do think there's a role for antifungals, but probably their usefulness is limited by the day-to-day exposure that people are getting at their house, if that's an issue.
And I think that's where the Joe Brewer and Neil Nathan kind of approach builds on the shoemaker work, where they will use sinus and gastrointestinal or systemic antifungals. I know there's still a lot of debate and discussion about that, but certainly have talked to people where the antifungals that they used orally or in the sinuses or whatever did seem to move them forward. So right. I think that's definitely an interesting perspective. You get stuck on the whole limitations of lab testing. I mean, my wife is a physician in our practice as well, and she had a patient who was treated for SIBO, and it was kind of a little bit better, but my wife wanted to treat her with some antifungals, and she's like, oh no, I had the diagnostic solutions test, or the Genova, whatever it was, there's no fungus in there, so therefore that's not part of it, so I don't want to take any antifungals. And I get that, but I think that it fails to appreciate the limitations of the testing. So I think maybe that's those same limitations, I think, play into the shoemaker people. And shoemaker is a guy who really likes his labs, and so I mean, if there isn't a good way to figure that out, I think it's not going to be a part of his protocol. So any thoughts? Do you see many people in your practice with mast cell activation syndrome?
No, I don't. I haven't had that. I mean, it may be that they're out there and I'm just not diagnosing it or whatever. I guess my, just a quick thought on it would be that it seems like, if you're really toxic, if your detox pathways are the highway at rush hour, then you're going to be slower to metabolize things that activate mast cells, slower to metabolize, cytokines and leukotrienes, whatever cell messaging molecules are also, needing to be broken down in order to function properly. And so I think that may be part of it. I do feel like these patients are more toxic than, I mean, all of our patients are toxic to some degree. That's such a big part of this whole picture. But I think like those MCAS people are maybe more toxic, and maybe we need to focus even more on detox with them, but also killing the things that are making the toxins. And that's the whole thing in a nutshell, I guess.
Yeah, and it's interesting because I think the good thing is a lot of your work is focused on removing the triggers that are the underlying cause of the mast cell activation, while, whatever else you're doing treatment-wise. I mean, I think what a lot of people do is maybe they take things that are antihistamines or mast cell stabilizers or whatnot, but if they're not also doing something to get out of the mold or deal with the parasite or deal with whatever the trigger is, then they're probably not making lasting progress in terms of those reactions. So I did a podcast with Jill Carnahan on this topic, and it was fantastic. I am a huge Jill Carnahan fan, but one of the challenges with this as well is like there aren't any really good tests. And my understanding is that these reactions in the body kind of change from second to second, minute to minute. And so, you could do the test and they could be very different. And so I'm hoping that at some point, similar to what we have with the Cunningham panel in the world of pandas and pans, that someone comes up with a functional mast cell activation panel that kind of pulls it all together. I haven't seen that yet. I'm sure it will emerge, but that certainly will be helpful. So when you're treating a patient for Lyme or other chronic illnesses and they're kind of nearing the end of their treatment, what is your ultimate goal? Is the goal that they can stop their treatment? Is the goal that they need to continue some type of maintenance antimicrobials once they're essentially kind of done? And then I know we talked a little bit about, as people near the end of their treatment, you mentioned that you have this kind of neuro flare that some people see, and that kind of plays in here too as well.
Yeah, I think that, well, actually the neuro flare, I think, is actually not so much the end of treatment. That's like 6 months in, you finally got the Borrelia cornered, you give them Tindamax, and then, and then they get this, spirochetes spill into their brain from cysts. But I think that I want people to keep coming until they muscle test like they've got nothing, like they're clean, and like they don't need any treatment, and that does happen with a lot of regularity. Not everyone gets to that point. Some people are still coming, and some people stop coming. But when people do get to that point, I feel like my relapse rate is less than 20%. And I would, I really only consider it a relapse if I got somebody to that point where, okay, you came in, you muscle test, I couldn't find the bugs, I couldn't find, the need for antimicrobial remedies. Maybe you needed a little more apohepat or something, just to kind of clean up the mess left behind by all these things. And yeah, some of those people come back, and it's interesting. Sometimes I see the Lyme bugs again, which means that I was probably wrong and they weren't gone. And I think that sometimes I'll just see like a mycoplasma. I see that significant portion of what looks like a relapse. I'll just see mycoplasma, and then that's easier. A few weeks of treatment for that, and it seems like it's gone. And was that just a deeper layer that was so far down that it needed 6 months before it popped its head up? Or maybe they just took a plane ride and got showered by that mycoplasma nozzle.
Well, that's what I was going to say as well. And one of the things about mycoplasma, because I see that all the time also, at the last Shoemaker conference, they were talking about the things that are significantly higher in water damaged buildings, well beyond the mycotoxins, which he now says is only about 1% of the problem. But things like VOCs, microbial VOCs, and interestingly, mycoplasma and chlamydia were also on that list. And so,
really, I had no idea. That's really interesting.
Yeah. So apparently, if you are in a water damaged building, your exposure to mycoplasma and chlamydia pneumoniae is higher than otherwise. So I often wonder if people just get exposed to mycoplasma. I mean, I think we do get exposed to mycoplasma all the time. So maybe it's just a re-exposure in some of those people. And then because they've dealt with it before, maybe the immune system tends to overreact or react inappropriately to that re-exposure. I don't know.
Well, that actually is very timely for me because somebody started tearing out my bathroom 10 days ago, and I get puffy and tired, and I'm still not right. And I'm getting muscle testing for mycoplasma stuff. It didn't occur to me that it might be the water damage. I just thought it was another patient coughing on me. Damn it. That happens every year.
So let's talk a little bit about your idea of the word cure. So do you think that patients do when they stop muscle testing for these? Do you think they often have eradicated these bugs? Is that kind of a goal of treatment? And how do you define cure based on your patient experiences?
Yeah, I think that we should shoot for that. And I mean, there's some pretty sick people that come through the door that I think, I don't think I'm ever going to get to that place with this person. But, you said often, and I think I like that word. I think often is appropriate. And so there's no question that that some of these people are going to relapse even when I think they're cured. And so I'm not going to say that my muscle testing isn't missing some of these things when they're hiding in some dark corner. I have gotten better about using the muscle testing to look more carefully for things. And I think that has reduced my relapse rate somewhat. But you don't want to give anybody false hope, but I also don't like the way that people are coming in having read things online, leading them to the conclusion that these things can't be eradicated. And so, I feel like sometimes that leads to a victim mentality, and I think that can interfere with recovery, and just sort of having that in one's head that this is never going to totally go away, so why bother fighting it? I think that's detrimental to people's recovery. So that I don't like that, and I know that leading authorities in the Lyme world are not afraid to say that these things are incurable, and I don't think that's appropriate. I don't think that's correct. I think that this is a hugely variable clinical entity, and you've got so many there's so many infections and co-infections and secondary infections and genetic variability and immunity and genetic variability and detox and what's your diet and what's your all these things that we've talked about already, and so you could never narrow all those variables into a meaningful clinical study, and that's why yes, Lyme should get more research dollars, but there's always going to be a need for clinical judgment and individualization of treatment for patients. But yeah, I think that most kids can be cured, and I think that most senior citizens that come in with a neurodegenerative disease, not really pleased with where we end up, and I think that most people are somewhere in that gray zone, and some of them surprise me on both sides. Some people get better and stay better, and some people are head scratchers. But I've also been doing this long enough now that I've had a few people come in 4 and 5 years later, still feeling good. Hey, can you give me a checkup? Or hey, I got this other thing I want you to look at. I'm like, hey, can I muscle test you for Lyme disease? Don't find it. They're feeling good. I think those people, especially if they've been through a car accident, and they've had a kid, or they got a divorce, these things that you would expect to bring back the Lyme disease if it was just quietly waiting for an opportunity. And so I think that yes, it's curable. It's not always curable. Often it can be cured, and most of the time people can get better. And yeah, some of those people are still harboring it, and maybe just one stressful event away from a relapse, but still they got better, and that's reasonable to hope for.
Good. Great perspective. I appreciate that. So you mentioned the victim mentality. In all the years that you've worked with people with chronic illnesses, how important is the role of mental, emotional health, and how does that impact their outcome?
The notion that the conscious mind has a profound effect on the physiology is counterintuitive, I think, to most people, and yet the science of that phenomena is pretty strong. You can just Google psychoneuroimmunology or psychoneuroendocrinology. So there's research that shows that that's out there, but but yeah, people coming in with the with preconceived notions about not getting better. I know Klinghardt has done a lot of great work in this field, talking about people who needed to fit in with a family of people where everyone else was sick. That's sort of you can't say to somebody who's sick and looking for and hoping to maybe get some help paying their bills through like a disability program. You can't tell those people that that having a subconscious disincentive to recovery, a subconscious incentive to not recovering, be it that I need to be sick in order to get disability. You can't really say to those people that. You can't tell them that, they freak out. and yeah, they are legitimately sick and they do need help and they deserve it, and they often won't get it because the Lyme is so controversial, and because these disabilities, especially the private disability insurance companies, will lean on anything they can to discredit. All the controversy in Lyme is fertile ground for their denials. And so anyway, we have someone in the office now who's doing great work with neuroemotional technique, which I know there's different names for different things, but she's doing some eye movements and some EMDR and some Bach flower and some laser, and
nice.
And she's just a great person, and people really feel comfortable with her, and she uses muscle testing to help guide her treatment. And I've seen her situations where people were just really stuck in 2 or 3 treatments with her, and they're rocking and rolling and turning the corner. And so I know that's important, and I know now that I need to leave it to her because I don't have time and I'm not good enough at it. But I'm really glad to have that as a tool because I think it's very important.
Yeah, that sounds fantastic. So what do you do to optimize your own health on a regular basis besides tearing out your bathroom?
Right. I definitely feel less healthy since that started all over again. I'm trying to be gluten-free and dairy-free, and I guess most people in my practice already are, which is a sharp departure from most people who are not in my practice. I think people talk about anyway. So that's an easy one. Gosh, Scott, I don't know if I'm the right person to ask about that. I probably don't do as much as I should. I don't really like to exercise very much. I'll chase after a tennis ball, or I'll ski until I can hardly walk. But I don't want to lift weights, especially given how moldy my basement is apparently.
All right, cool. So if people are interested in learning more about your practice and the work that you do, where can they find you?
My website is soundclinic.com, and there's not a ton of information on that, but it's a good place to find me. And all of our practitioners are listed there and our locations. And so yeah, I'm happy to help. We all take insurance, which is pretty unusual given what we do. And
very unusual. Yeah.
Yeah. It's well, let's not get into money. It's gauche, right? But yeah, we have a new practitioner that started recently. His name is Mike, and he is just going to be outstanding. I'm really excited to have him on board. He's got a better temperament for this than I do, and a lot of experience with Lyme and mold. And so he's at our Louisville office, and I'm sure he's going to be busy soon. But for now, he's pretty taking new patients in the next few months, and so that's good for people who need to be seen soon. I'm glad for at least for a few months we're going to have the ability to accommodate those people.
Yeah, that's fantastic. This has been a fun conversation for me. It's been very insightful, lots of good observations and things that you've been able to share with people that are listening. I appreciate it. It's been fantastic knowing you over the past decade. I can't believe it's
been that long. You said that, I was like, no, it can't be really that long.
I actually think it has been about that long.
I think that's true.
So appreciate it very much. Thanks for your time, and I look forward to talking with you again soon.
Thanks again, Scott. Really appreciate it.
To learn more about today's guest, visit soundclinic.com. That's soundclinic.com. I appreciate your support of the Better Health Guy blogcasts series. If you'd like to follow me, you can find me on Facebook and Twitter as Better Health Guy. The show can be found on YouTube, iTunes, Google Play, and Stitcher. If you'd like to support the show, please visit betterhealthguy.com/donate. And if you'd like to be added to my newsletter, please visit betterhealthguy.com/newsletters. I'm looking forward to many more shows ahead and appreciate your interest.
Thanks for listening to this Better Health Guy blogcast with Scott, your Better Health Guy. To check out additional shows and learn more about Scott's personal journey to better health, please visit betterhealthguy.com.